Good afternoon, and thank you for joining today's joint COVID panel discussion, bringing together experts in healthcare technology management, infection control, and sterile processing. I'm Danielle McGeary, AAMI's Vice President of Healthcare Technology Management, and with me is my colleague, Amanda Benedict, AAMI's Senior Vice President of Standards. If we have learned anything from the COVID-19 pandemic so far, it is the great importance of collaboration and multidisciplinary teamwork across healthcare disciplines. Today, we have Damien Berg, a sterile processing expert from UC Davis Healthcare of the Rockies, Dr. Samantha Jacques, an HTM leader from McLaren Health, and Bethany Phillips, a subject matter expert in infection control from Children's Health, who will be highlighting areas of alignment for patient and worker safety and important lessons learned in each of their respective disciplines. Today's webinar is worth one CEU towards your recertification. All attendees today will receive a participation certificate via email from GoToWebinar 24 hours after this event. This webinar is also being recorded and will be posted on AAMI's COVID-19 webpage, which is aami.org/COVID-19, to watch on demand at any time. There are also many other great COVID-19 resources on that page, so please visit it and take advantage of those resources. We will also be taking questions at the end of the webinar. If you have a question, please type it in the questions box in the lower right-hand corner of the GoToWebinar control panel. We will answer as many questions as we have time for. To date, the United States has had over 12 million COVID-19 cases and sadly, almost 256,000 deaths since January of 2020. With cases rapidly on the rise in many areas of the country, we hope the information in this webinar is helpful to you all fighting this battle on the front lines of healthcare every day. On behalf of everyone at AAMI, we want to sincerely thank the millions of healthcare warriors who are selflessly out there ensuring patients are well cared for during these very dynamic and challenging times. At this time, I will turn it over to my colleague, Amanda.
Thank you, Danielle, and many thanks to our speakers for joining us today to share your experiences and your expertise with the healthcare community. We're really looking forward to today's conversation. I want to give each of you the opportunity to introduce yourselves and explain a bit about your roles and your work. So we'll start with Dr. Sam Jacques.
Hello, everyone. My name is Sam Jacques. I am the Vice President of Clinical Engineering at McLaren Health. We have a 15-hospital system in Michigan and Ohio. And I take care of course, all the medical equipment from the HTM side for all of those 15 hospitals. I have rural hospitals. I have hospitals that are in centers, and like I said, across state lines, which has been quite a challenge related to some of the COVID stuff. So thank you very much for inviting me, and I look forward to this.
Hey, thank you, Sam. Bethany?
Yes, I'm Bethany Phillips. I am the Program Director of Infection Prevention and Control at Children's Health. And Children's Health is located in Dallas, Texas. That's where our main medical center is. It's located in an academic environment with some counterparts that are adult facilities. And then we have a couple others of our smaller hospitals that are in the Plano area, and then another more long-term facility that is in Dallas as well. I kind of got involved with AAMI because through our national organization, which is APEC, which is the Association of Professionals in Infection Control and Epidemiology, through that practice guidance committee that I'm part of, we are involved in the AAMI standards. And so that's kind of how I got involved in AAMI, and I'm happy to be here.
Okay, thank you, Bethany. And rounding out our panel, Damien?
Well, thank you, Amanda, and thank you all who are in attendance today, and my fellow panel experts and the AAMI staff. My name is Damien Berg, and I'm the Regional Manager of Sterile Processing for University of Colorado Health. I currently have direct observation or oversight over two large hospitals, Poudre Valley Hospital in Fort Collins and Medical Center of the Rockies in Loveland, Colorado, and a small surgery center as well. I'm the co-chair of all cleaning, sterilization, and disinfection for UCHealth in Colorado, so 16 hospitals, multiple clinics, multiple what I call dock in the boxes offices and things like that. So my scope of sterile processing is pretty vast here in Colorado, but I absolutely love it with a passion. On top of that, I'm the past president of ISHM, which is the International Association for Sterile Processing Techs. So I finished up my presidency in May of 2020. So that was 2017 to 2020. So I helped represent some 36,000 sterile processing techs around the world. Now that my presidency is ended, I find myself traveling, well, pre-COVID, traveling the globe and the country, meeting with counterparts, both in the biomedical engineer space and definitely in the IP space, and most likely in the sterile processing peri-op space. Sharing commonalities, sharing best practices, listening to what their needs are. I've had the luxury of traveling the world from Dubai to Germany to France to Mexico City to the Netherlands to Canada, obviously, just really meeting the global community which we are part of. And then on top of that, finally, I've been an active AAMI member since 2006, 2007, where I've served as co-chair 3 times on AAMI standards, and I'm a multiple committee member as well too. So I stay very active, and I am one of the U.S. experts to ISO as well too on reprocessing instruction. So I live and breathe everything that this is, and I'm excited to present alongside Sam and Bethany and share our knowledge on what we went through, but most importantly, what we are all going through again. A little bit of deja vu, but a different flavor. So we'll dig into that. So thank you all.
All right, great. Thanks again to all of you. So to get us started on our conversation, we want to set the stage here a bit and get a sense of what all of you are seeing. We know that infections are on the rise across the country, hospitalizations are on the rise, but what are the current trends in your general area and within your facility as far as hospitalizations due to COVID-19?
I can start. It's Bethany. So in the Dallas area and Texas in general, you've probably watched the news and seen some of the crazy things that are going on in Texas. In Dallas, we are having a spike. Our bed occupancy and ICU bed occupancy, just for in general, we're probably about 80% occupied. And the Dallas COVID hospitalization rate is around 14%, and it keeps going up. That's the 7-day average. We just keep getting more and more cases each day. And in our hospital, I'm pediatrics, so we typically don't see as many admitted patients that stay long-term admitted. Most of our patients are in-house for maybe a day or two, but we do have some long-term patients that are here in our ICU. We have some HEMOC patients that are here that end up staying a long time for cancer treatment. So that's kind of what we have going on in Dallas.
So in Michigan and Ohio, most of my hospitals are adult hospitals. I don't have a large pediatric population, but we are running about 90 to 99% full across the states. And I will tell you currently about 32% of our hospital admissions are related to COVID. We are one of the few systems in Michigan especially that has not closed for other cases. And so we are still doing a lot of urgent and emergent stroke and heart replacement type cases as ICU beds become available. But obviously, you know, with a census somewhere in the high 90s, that becomes very challenging. We are in a really rough situation the second time around, generally because it's hitting all of our hospitals at once, where the first time around in March and April, it was really only hitting 3 or 4 of our hospitals. And we really could allocate resources from one place to another to make it through. This time around, across the state, we're seeing really high rates of transmission and really high rates of positive testing that has caused not only issues in our med-surg areas, where it started out probably 2 or 3 weeks ago, but now it's escalated into our ICU areas, and bed availability is becoming a true challenge in our system.
Yeah, and I'll tag on to that from you too. So I think, you know, hearing people around the country, which I talk to, the same trends I think are applying from most states, and Colorado's got no exception to what's happening in our fellow presenters states, Colorado and especially UCHealth. Same thing, we are at the point now in several hospitals evaluating because of the bed space availability. The difference is when we initially started, we shut down surgeries. We shut down elective surgeries for the state and for our healthcare system. This time we're not doing that. We're evaluating the bed space availability because we know our patients need surgeries. Not having surgery is not an option. It's not like the patients just miraculously heal. So we're continuing to push forward with surgeries and patients who need beds, but also, again, as stated by my peers, is it's 90, 95+% full already, so balancing all that. But more importantly, we're also shuffling nurses. Our ORs have been slowing down because we just don't have the capacity in the hospital. So we're picking and choosing literally on a 24-hour basis which surgeries move forward based on their criticality and our bed availability, and most importantly, our staffing availability, because we are needing to send nurses and other clinical professionals and some of the sterile processing professionals to other units to help them out with the surge. So then that reduces our capacity to meet the surgery demand, even if it's elective ACLs and arthroscopies and simple surgeries that can come and go. We're challenged with finding the staff to actually support that, not only the bed space, but the staffing. So we're currently doing that, but I'm pretty proud of our leadership team here. I'm pretty proud of the staff. The communication's amazing. We have multiple meetings daily with decisions. Our doctors are very collaborative as well. A good example is we got an orthopedic group here, which I haven't seen a whole lot in the country that have done this kind of model where they have block days, as we all know. But what they've done is we told them, hey, we've got capability of this one hospital, for instance. Obviously, we can do 10 surgeries, orthopedic, 6 of them can go to the floor, 4 of them can be outpatient. That's our volume. They, in turn, are spreading that amongst their doctors so that every doctor gets a little piece. Instead of the one doctor having block time and filling up the entire space and taking all those spots, they're saying, okay, doctor, you do 2 of these here, 4 of these, this other guy does 2, this other does 4. And it's a pretty collaborative relationship. And we're even transferring patients from facility to facility and instruments and equipment and supplies. So if we got Dr. Smith that's always done surgery at one hospital, he's never gone anywhere else, but there's no availability, but I have availability in another hospital, we will pick that case up, the day before and move everything over to the other hospital if they don't have it. And working very closely with our biomedical engineering team, because it could be, generators and equipment and scopes and all that stuff that they haven't had in that facility. So moving the equipment, again, moving the soft goods. So we're working with our IP and our sterile processing stuff, and you can imagine all the loaners and all that fun stuff. We're removing staff that know how to work with the doctor and know those instruments and reprocessing. So it's a pretty interesting undertaking that this is our new world that we're dealing with due to the COVID surge compared to what we did to in the early stages in the March, April.
Okay, great. Well, before we head into our next topic, just a reminder to our audience to submit any questions that you might have using the chat feature. We will be taking a look at those when we head into our question and answer period later in the discussion. So for the group, thinking back to the very early days of the pandemic, what are some of the initial challenges that your team faced or your facility faced in responding to COVID-19?
I can start again on this one. It's Bethany. So I could go on and on. I could probably spend the whole hour answering this question, but I'm just going to highlight a couple of things. The first being access to testing. We really didn't have the testing available, and probably everyone was in the same boat. And when we did have testing, or we did have a physician that would request testing, it was very manual to get the actual test approved. It kind of went through a process of healthcare provider would page us in infection prevention. They would request the test. We would have to contact our epidemiologist on call at the health department, review the case with them back and forth. And if it was approved, it would be sent out to the CDC initially. And then after that, we had our health department testing. And that was really, the turnaround time was long. And so all of those patients had to be managed as persons under investigation, or PUIs, which required additional PPE, which kind of leads into my next challenge, which is PPE shortage. And we kind of thought early on we would have an issue with PPE shortage due to most of our PPE being managed and manufactured in that specific province in China. So we started looking at preservation methods pretty early on. Starting mid-February, we started developing different priority levels for how we would manage this. And the first we did was what we call a red box. And it's really just essentially a red box that was drawn into each room in the periphery, and we would let healthcare providers or staff go in that little section in specific rooms, so they didn't have to put PPE on. Another one of the methods we a little bit further on was after the CDC put the extended use guidance in for masks and N95s. That was pretty made everything a lot better in the aspect of we were able to use less. However, it also caused a lot of angst amongst staff and honestly amongst infection preventionists, because it's kind of a different mindset that we had always had, where infection prevention before had always said, you know, always remove your PPE after you exit the room, don't rewear it. And then this is kind of, let's keep it on as long as we can, is what we were telling staff. So, and as the CDC guidance evolved, that was really kind of another challenge for us. At our facility and our organization, we typically don't just hand out CDC guidance as the training for staff. We always make quick reference guides or videos or things like that that will actually go over what we're wanting them to do. And so as the requirements were changing, it required a lot of work to, you know, re-record videos, remake our guidance for the staff, and really just retraining the staff. Sometimes every day we would change things at one point, which honestly was confusing to us at one point, how to answer the questions, but then it also was really confusing and didn't really give staff a sense of that we are confident in what we're doing with what the guidance was, since it was changing so much. So those are kind of some of the things that I would highlight as some of the challenges for infection prevention.
Yeah, so I would echo Bethany's comments, especially around the pace of change. I think we struggled as well related to how fast things were changing and how to continuously get the information that you needed to make an appropriate decision. You know, I agree. At one point, we were making decisions based on guidance that changed on a daily basis, and that was really hard to communicate to staff, and it was really hard to even understand what direction you moved in. I think early on, we also struggled with equipment and where to get equipment. And obviously, in a world where your end users, your nurses, your doctors are used to model ABC of equipment, and the only thing you could find was something completely different, getting them up to speed on equipment they weren't used to using, getting disposables for that equipment, all of that was incredibly challenging very early on, because we didn't quite have a playbook as to how to deal with such a disruptive force within our health system. Like I said earlier on, we were very lucky to be able to have such a large health system and move stuff from one place to another to be able to meet some of those needs. But I'll tell you, transporting equipment from one place to another was a challenge in and of itself. You know, do you throw it in the back of a van? What happens if it gets, you know, damaged in the back of the van as you're moving it from one place to another? And really getting staff to do jobs that were very outside of their normal day-to-day. You know, asking our staff to work on weird shifts and asking them to do things that weren't necessarily part of their normal scope. That was all really challenging to begin with. I think after we got into a routine and we understood a little bit more about how the pandemic was unfolding, it got to be a little bit smoother, but those early days were very rough. Damien, do you agree?
Oh, absolutely, Sam. I do. You know, the interesting thing is I've done a couple presentations on this with different flavors and vantage points, but one of the things I just remember early on getting that call on a weekend, emergency activation call, that we were going to be shutting down the ORs and, you know, operating under this, you know, emergency operations center starting on a Monday, and talking to staff. I mean, everything that you two have said is spot on. I think we can all echo that and keep talking on it, like Bethany said, for the full hour. The one thing I'll focus on that we talked about is the staffing. You know, keeping the staff informed as much as we could, keeping them calm, because nerves were high, the unknown was high. People have got family, loved ones, little ones. We had issues with school, so how do we handle it, which we're doing again, but with a lot of lessons learned nowadays. But in the early days, it was really just telling people to have a little grace and have a little understanding and be patient with people, because what we saw, and we're seeing it again, is people were scared and people were tired and people were like, well, I've never done that before. I mean, we had sterile processing techs redeployed to COVID floors and COVID units to help clean and disinfect ventilators and restock anesthesia carts and respiratory carts and be PPE experts with our IP teams. Our IP teams, so they watch people don and doff PPE. These are sterile processing techs doing this. So we just said, be flexible, be understanding, have grace to other people that are not maybe doing well right now. That's really what I saw in the early days. I mean, I was stretched in, I was asked to do a lot of things, and I'm a big by the standards, by the book type of guy. And we just kind of had to throw that out and go, okay, what if we don't have this, what's the greater risk? So we did a lot of risk assessments in the early days that I have written down, and it's great to dust off again now that we have to do this, so we don't have to reinvent the wheel currently. But risk assessments, communicating with staff, giving people grace, those are really the early days that's I wanted to kind of highlight, other than what Sam and Bethany already said, because all that really applied to our healthcare system and our facilities. The other thing was different is the community support back then was amazing in Colorado. I mean, the towns, the cities, the citizens, they knew that our staff were working around the clock, and the food and the cards and the sidewalk chalk art and just the signs, they put signs up everywhere just supporting our healthcare workers, was just that extra motivating factor that we haven't necessarily seen as much this time around, because I think everybody's got a little bit of the COVID fatigue. But we're starting to see it a little bit, but not near as much as the early days. The early days was an outpouring of support and helping the healthcare workers across the spectrum, not just doctors and nurses, but all the healthcare workers, really supporting them dealing with this unknown that we had at the time.
I think it's interesting that you guys both mentioned how you would communicate with staff, and all of us being from healthcare systems. One of the ways that we kept everyone informed from our healthcare system standpoint, because we have clinics that are even in different cities and towns like you guys do. One of the ways that we did that as an organization was to have town halls that were weekly at one point, and then now we have them bi-weekly. And really just kind of had the key players for executives and someone from our department all going over what the changes were and what we kind of have a focus each week. And that really helped staff feel involved and like they were part of the decisions and what was going on. And I don't know if you guys had something similar.
Oh yeah, we did. We definitely did.
You almost had to, I think. Keeping your staff engaged and informed was almost half the battle throughout the first wave, and it's even more important this time around.
Yeah, I think now that staff have fatigue, they really are wanting to be. I can always tell when staff have fatigue because there's an increased amount of questions, and everyone thinks their questions the dumb question or the stupid question, because I think everyone's brain is just a little bit tired now, and so it helps to have someone, say that yes, you are doing the correct thing.
I'm sure if we could see the participants right now, we'd see a lot of people nodding in agreement with these challenges really resonating with the healthcare community. And Damien and Bethany, you both kind of touched on some of the ways that this has normalized, the situation kind of normalized or become the new normal. But thinking about what has changed or evolved in your facility, what are some of the biggest changes that you've seen as far as maybe policies or practices or just general changes from the early days of the pandemic to now?
One of the first ones big things I can think of is initially back in the beginning of January, we started travel screening at our facility. And that was kind of how we were gatewaying people in and out. So if they had been in a certain district that had high COVID numbers, we would kind of look at them more closely. Where now that's really not how we're letting people in and out. Now we're doing symptom-based and known exposure-based screening. So that's kind of helped. It's really changed because everywhere has high COVID numbers now. So you really can't use that simple travel screening mechanism. And then again, like we have the ability to test our patients. We can test people way quicker than we did before. Thankfully, it's a lot less manual. How I'd mentioned earlier, that big manual process of paging us. Now we have something built in Epic. So it's an algorithm that will lead the healthcare provider through different questions that kind of look at risks, kind of like a risk assessment that's built into Epic. It looks at things like is your patient going to be having, are they having symptoms? Are they having an AGP done or an aerosol generating procedure? So that kind of helps put them in a bucket for, they're going to either have a test that's quicker or they're going to have a test that maybe has a little bit longer of a turnaround time. We're doing a lot more contact tracing now that we didn't have that set up as robust as we do now. Now we have it for our employees and our patients. And then I'm sure you guys probably have the same. We have a special isolation unit. That is something that came about as we got more and more patients, where if a patient, we have ICU patients that are in the ICU that kind of are a little bit put off to one side, but then we have an SIU that is has all of our patients that can go to a regular nursing floor. And then again, I'm sure you guys all know, as we're doing it now, everything's virtual. Anything that can be done virtually, virtual health, anything that can be, all of our meetings moved to virtual. So that's kind of something new, I think, that healthcare really hadn't been utilizing before, where now it's pretty robust in our area. And I'm sure you guys probably can having more virtual health visits than you did before as well.
Oh, yeah, absolutely,
yeah.
Bethany. I'll tag on to that. I mean, one interesting stat just in here, prior to COVID, our virtual health visits with their providers was somewhere between 500, 800 a week. After COVID, and still currently going on right now, it's close to 5,000 a week now. So it's just amazing. They change, and we're talking all spectrums of population and generations and everything else are very comfortable. But with that, we've also seen some unforeseen side effects with that, is where people may not go to the doctor when they need to, or go to the urgent care, or go to the emergency room when they need to. It's cut down a lot on our emergency room visits. Initially, we're seeing an increase right now for the obvious reasons we all know. But that was definitely one thing that's changed that we had to deal with. The other things we're doing is reclassifying our surgeries. Is not necessarily like elective and non-elective. It's tiers, tier 0, 1, 2, 3. Tier 0 being that, trauma that comes in. Tier 1 being that acute appendix. Tier 2 being that, total hip knee that's causing the patient pain, but maybe they can wait a little bit, maybe they can't. That's reviewed by the medical providers. And then tier 3, maybe more like that carpal tunnel or that hernia that can definitely wait, truly the real elective type of surgery. But that's helping us plan our future schedule, our days, our equipment, our staffing. It is so helpful to know what's out there on the grid, but also virtually doing a lot of this work. I mean, again, I work for a large healthcare system, and I operate out of 3 facilities, and I predominantly just stay at one all day long, and I rotate day to day, but I can do everything virtually, which prior to COVID, I was required to drive face-to-face every day to multiple facilities. So a lot of wasted time on the road. So I'm finding myself a lot more productive in this time.
And I would echo, what Damien said, especially around, taking care of patients. I think the first time around, we were very cautious, and we canceled a lot of procedures that, in retrospect, actually harmed patients. Right? There were cases that should have gone forward, and we're especially seeing them in our cancer care. We have one of the largest cancer groups in Michigan. And so we're seeing these patients now that are very much sicker than we would normally have seen them. And so this time around, we're being very cautious, just like Damien is, around what absolutely has to be done and what can't get put off. We don't want to close, right, and really deny care to those patients who absolutely need it. And so that tiering structure is something we've been working on as well, to try and get those patients who are urgent and emergent and really can't wait seen in a reasonable amount of time. I think the other thing that I would add, and both of you kind of alluded to it, was the change in the way the hospitals are looking at some of their finances. I know all of us had really hard financial outcomes because of the first wave of COVID. And so we're really changing the way we do a lot of things because of that financial hardship, whether it be looking at capital a different way, whether it be looking at renting versus buying, or other types of tools that we have. We're looking at staffing models. We're looking at all kinds of things very differently that I think pre-COVID were either really not we didn't really want to go there because it was too hard, or there were too many preconceived notions. I have to say COVID wiped away a lot of those, and we're now talking about things we should have been talking about for years, and improvements that we've been able to make because of COVID. It just gave us that push to really force a financial outlook on us to be really smart about what resources we have and how we're going to utilize those.
I agree. I think preventative healthcare kind of suffered a little bit as part of, as education a little bit suffered during this. Preventative healthcare did in children for sure, because they weren't able to go in at some certain points and actually get things like vaccinations. So we kind of prepared for some of those clinics to maybe potentially see more vaccine, preventable illnesses coming in. We were hoping we wouldn't see something like measles, which, knock on wood, we don't see that. But that's something else we thought of for children that really kind of wasn't on our minds when we were closing things initially.
Okay, you had mentioned shifting staff to support needs across your facility, and how has your team or your facility staffing model changed or been adapted?
So, I'll start off on that one. I think, and you heard me talk about redeploying staff when the ORs were what I affectionately call asleep. But now that the ORs are open, we've actually heard probably some of the more efficient ORs I've ever seen in my 28 years of doing this. The reason why is we've changed our scheduling models. We've kind of said, docs, this is what we're going to do. So we've really stacked the rooms very well. They're operating to 90% block utilization and on-time starts, where we couldn't get near that prior to COVID just because it's culture. So, but with that though, it's had an unintended impact on staffing, where the traditional staffing models really are out the window. We really staff to demand now, which is an interesting thing, not only dealing with COVID, but also the surgery. So we're staffing to a more efficient staffing model we've not had, or a surgery model we've not had, which is different, but also working with COVID, because that just creates its own challenges, because we could have cases cancel the night before, the morning of, for a multitude of reasons, COVID related or room availability, and we have to staff. So now that case moved to 5 o'clock at night. So my staff have been very good at me, messaging that, hey, yeah, you may be a 10 o'clock person, but now I need you at a noon, just because we're going to be running later cases. Or, hey, do you want to take today off because I'm going to need you to work Saturday, because we push a lot of cases onto Saturdays and Sundays to help alleviate some of the and decompress the hospital. So by just being upfront with them and letting them know that they're going to get their 40 hours if they're flexible on their times. And we've had a lot of people we had to flex because of childcare issues. I can't tell you the number of times I've had, someone says, hey, I can't come until 6 o'clock at night now. Well, but that helped me now because I'm running later surgeries because we're stacking the cases. So it's just this fun dance that we've come to learn, that you don't need your traditional staffing model to meet the demand of the OR and the hospital.
Yeah, I agree completely. I think the other barrier in our world that got broken down, historically, all of my 15 hospitals had biomeds that sat at those hospitals, but they didn't necessarily cross the line into a different hospital. And I think COVID really gave us an opportunity to share resources across sites, and show individuals that it's okay, right, to move resources from one place to another to staff to the work. And so we've done a lot more of that, which, prior to COVID was very verboten. We really frowned upon that. But we had to get really flexible about models. And so moving staff from site to site happened. I'll also tell you, during COVID, we went into a model where I split my staff in half. We had an A team and a B team, and the A team never saw the B team, so that if one of them caught COVID and I lost half my staff, I wouldn't be infecting the entire department. We're implementing that again as we go into the second wave here, but that really reduced the risk from a sick out kind of perspective. And it was successful for us. But you're right, telling staff members, hey, you used to be an 8-hour-a-day person, and now I'm moving your schedule to 12 hours a day, and you're only going to work 3 or 4 days a week, was really challenging to begin with. But our staff has really worked with us very well. And because of their challenges, been very flexible. And I do appreciate that. I think we broke down barriers that would have taken us years to get to without this pandemic. So there's at least one bright side related to it.
Yeah, as Sam was mentioning, we also do A team and B team in our department currently in infection prevention. We always, at first, we were there all the time. It was way too many changes for us to be, away from each other. But once the shelter in place happened, we were still on call 24/7. And we, at the time, would actually have a backup person on call because, It was just so many calls coming through. But during the shelter in place, we would only have one person physically in the hospital at a time. But now we do the A team and B team and rotate off. And our policy for the hospital, actually HR developed one that had put our employees into 3 categories. So there's one group of employees that are now classified as remote, and they are only remote. And then there's hybrid employees, which infection prevention falls under that. We work more in the hospital, but we do work from home as well. And then there's the on-site only employees, which probably majority of you HTM and SPD people are probably almost all on-site. But we're lucky to be able to do a little bit of hybrid in our department. And again, like we did the same thing. We had a pool of employees that at one point in time, we weren't having high risk employees come in. This was very, very early on. And so, and then if your area, like our ambulatory surgery center was closed temporarily, those employees would go into what we considered a pool of employees that were available to work other areas where we're needed in the hospital. And so we would have maybe a clinic nurse that was working in the cafeteria. So we had, everyone was utilized in different ways, and everyone was really good about showing up and wherever they were needed. And then just planning now, it's in pediatrics, we typically always have really hard cold and flu seasons. And so we've kind of been planning that way where we have additional work, winter employees that are only here for winter, but then also keeping in mind that, you know, we don't have as many things. We don't have our ER visits are not as high as they were before, like kind of like how you guys were mentioning. So it's kind of balancing the two of having availability there, but then also not having too many people available. So our full-time employees can't get their hours in.
That's the spirit of pulling resources together is actually a good segue into the next question. HTM, sterile processing, and infection prevention and control all have key roles in supporting patient care, and all of you have alluded during this conversation to cross-organizational communication being key. So I'd like to shift this into talking about other multidisciplinary approaches that you've put into place, and how your facility has pulled together these 3 disciplines, HTM, sterile processing, infection prevention, and control, to work together for improving outcomes for patients and also worker safety.
So I'm happy to start this one. I think on our end, one of the unique projects, and I talked about, you know, following the standards and the FDA guidance and IFUs, I don't want to say went out the window, but we just had a different playbook that nobody knew how to read. And the first one that really presented a challenge to all of us was the shortage of PPE, specifically N95 masks. So our system leadership, very collaborative and very informative, said, here's the reality. Here's where we're at. Here's when we're going to get in trouble. You know, but they got our IP team together. We got our biomedical engineers. They did include sterile processing and said, okay, we want to reprocess N95 masks. We want to disinfect N95 masks. How can we do it? And we dusted off, you know, plans from Nebraska, plans from I got a hold of some of my Europe colleagues, stuff from Maryland. There's a lot of good stuff out there that's been done in the field of, say, UV, but we needed to really dig into that. So the collaboration between the biomedical engineering team on the machines and the units and what we needed and how we need to do it and all the parts, because we didn't have these units and machines, or were we going to use our low temp vaporized hydrogen peroxide sterilizers? What's that about? And then dealing with our IP teams and really looking at the science behind it, both for the efficacy for the safety of the patient, but also the safety of the staff. Really, if we're going to do something, what's going to be making sure we're not, you know, injuring the staff, not just now, but in 5 to 10 years from now. One of my backgrounds that I didn't tell you guys, I served 21 years in the military as a combat medic. And I remember being one of my tours in Iraq is we had a lot of burn pits around us. And 2 things that I'm now suffering with nowadays is we had burn pits, and they burned medical waste, and they burned all this everything that we could on the forward operating bases. And they said, well, it's fine because it's outdoors, you won't have a problem. Years later, I've got what they call burn pit lung. And I thought about that a lot when we were doing reprocessing of masks, and I work with my IP and my environmental care folks and going, I don't want to do something now that everybody thinks is safe and then have a nurse or a provider or someone that used a mask that we reprocessed causing them health conditions later on in life. So the collaboration between my IP, that's above and beyond my scope or my background as far as that type of stuff. So I leaned on my partners to help me and reassure me, and so I can reassure my team, that we can reassure the clinical people that we are doing something safe for them so that we can treat our patients. And the biomedical engineers were by our side. I mean, I gave them a challenge, and it was just funny watching them almost like a little strike team come in and make a room for me full of UV stuff and distancing, and they read all about it, and we had backup light bulbs and all this other stuff. It was just impressive to see that work. So that's my story on the collaboration. And there's so many more, but that one sticks out in my head.
We did the same as Damien. We all collaborated for our N95 reprocessing. The proposal for how the room was set up was pretty much done by infection prevention and then some of our engineering people. But HTM really helped validate once we had that proposal for how it was set up, just to make sure that every single respirator that was hanging on that line was actually getting the UV rays necessary to disinfect. And then our SPD staff came in, and they're the ones that really, once we had it up and running, they really ran the show. They did all of the reprocessing daily. And honestly, at one point, it was a lot. It was a lot of N95 respirators. They were reprocessing, labeling. It was a huge undertaking and took a lot of time. And another kind of area that I feel like we kind of capitalized on with the group of three of us, the HTM, sterile processing, and infection prevention, was just really the additional exposure and importance of cleaning and disinfection that is now on everyone's mind, where I don't know that everyone saw it. I think sometimes people kind of thought, oh, well, maybe we're just nagging them to get them to clean these things, or it's not that important, where now everyone thinks it's important. So one of the things that we did was we actually did a risk assessment of there's a shared space for SPD and in our medical equipment techs. We did a risk assessment on that and why we thought they needed more space. And actually that risk assessment was put to our command center, which is running through our HICS structure. And they agreed, and they thought this is a good plan. And so actually on next Monday, I'm presenting it to our executive leadership to hopefully, again, like kind of capitalize on the importance of our departments and on the experience, and get those two locations and two departments more space, which I think if there's anything good that came out of it, this is something that we could see as a positive for regulatory and then just for the ability to do their job properly.
And I echo both what Bethany and Damien said. I think, the collaboration, especially around reprocessing, was very, very difficult, and it really took all three of our groups to come together to get that right. One other example that I have to share related to how we work well together is very early on in the pandemic, we were looking at options to use anesthesia machines as ventilators, which is not something, obviously, a lot of us do, and thank goodness we didn't have to do that. But our three groups were actually very instrumental in understanding exactly what it would take, how to test appropriately to make sure we were keeping both the patient safe and our providers safe, as well as how to process and clean, right, any of the anesthesia machines that would have been used. Because we were looking at something that obviously wasn't necessarily a primary intended use for that piece of equipment. And so, like I said, thank goodness we didn't have to resort to that. But I think these three teams coming together to really work through problems is something that was outstanding as part of a response to the COVID-19 pandemic.
Okay. Well, we're now seeing some pretty grim models related to infections for the coming weeks. And of course, there's also some promising news as far as vaccines. And while we can't predict exactly what the short term or even the long term is going to look like, the question I would pose to you is, looking ahead, what will be different for your teams and for your facilities in responding to COVID-19 needs?
So I think I can answer this to start. Again, vaccination planning is huge, and how we will get staff vaccinated, who will do it, where, how. I mean, there's a lot of different aspects that come into play with vaccination. And then I'm hopeful that there's going to be less change overall, and so we can get staff more stabilized in our practices. I feel like that's kind of already started, but there's still changes happening. And then eventually, my hospital's been in the HICS structure since I think pretty much early March, and eventually that will have to change. We will have to eventually probably go out of our HICS structure, and I don't really know what that looks like, but it's something that has been on the minds of the people that are involved in our command center. And so I don't know, are you guys using the HIC structure at your facilities? It's kind of been a game changer for us in making sure everyone's on the same page.
So Bethany, our organizations were in HICS to begin with in March and April, and we actually closed our command centers, depending on which hospital, sometime in the June, July, and we've opened them up again. But to your point, I think, constantly being in a state of emergency is very challenging. And I think what's different this time around for us is the first time through, you had a lot of support, not only from the community, but also from your staff members. Everyone wanted to band together to figure this out and get things right for the sake of our patients. I think this time around, one of the challenges we're having is everybody is tired. And everybody has been through this for a very long time, and finding even the emotional resources to continue on is challenging, and it continues to be challenging. And so to your point, we don't necessarily have to go through change management as fast as we did previously, but we have to find a different way to motivate staff and keep them engaged and motivated to continue doing this very difficult work. And it's truly burning people out. I think that's going to be the big challenge. Hopefully vaccines can come fast enough and be effective enough to help us get out of this rut. But to me, that's really the difficulty we're facing right now.
Yes, and I echo both those. I think, we're seeing the mental health fatigue and the mental health challenges like everybody else is seeing. You just don't. This is not a sprint. It's not even a marathon anymore. It's an ultra marathon, and a lot of people weren't developed for that, not designed for that, not trained for that. Who could be trained for this? So that's definitely a spot. The other thing that, and I think it was Bethany who said this earlier, is the good thing about COVID is it kind of created a hyper sense of awareness around certain things where people may have not been doing things. One of the common questions I got on COVID was, how do we know you're properly disinfecting or decontaminating surgical instruments or whatever we were cleaning and killing the COVID? Well, COVID's actually in my world, COVID's a very easy bug to kill. All the processes we have in place in our decontamination area and sterile processing kills COVID just fine. But it put an emphasis to make sure you're doing them properly, using our universal precautions, brushing and flushing underwater, not above water, so you don't aerosolize. All the standards that we got certified from and trained on, it just showed how important they were to do and to follow. My concern right now is, again, as we talked about, is the fatigue. Are people going to get fatigued of washing their hands, of properly doing the right steps, whether it's on the floor, in a unit, in sterile processing, because you've been doing this pace for so long? So my goal is, wherever I'm at, and I empower my leaders to do this in all levels of leadership, is to round in all areas of my department daily. Don't get stuck up and get tunnel vision into the work of the day. Round and check on the staff, check on how they're doing, see if they've got all the tools and the training. And there was one hospital that was running out of PPE gowns, and they were using trash bags, not mine, but a different hospital. And I was like, are you kidding me? When we have other hospitals with plenty of gowns or PPE. So it's like they just thought that's what they had to do through the fatigue of doing this. So doing things right, looking at what your staff's doing, communicating with them, and really being where the work happens, to me, is where I'm at, and that's where I'm directing my leadership in these times.
Okay. So one final question before we move into audience question and answer. What is the biggest or most important lesson that you've learned during the past 8 months of working through and living with the COVID-19 pandemic?
I can start. I think obviously we probably all have the same answer of the importance of being able to adapt and being at a facility that supports adapting and gives you the resources that you need. And then honestly, I think one thing that really hit home to me is just how essential all of our jobs are in healthcare. I think sometimes we see in commercials and on the news, we see the bedside nurse, we see the healthcare physician, but really all of our positions have been very important positions, like the IT department, that it would have completely changed our response. If we only had bedside staff, we would have been in a world of hurt. And then I think lastly would be, we guys are kind of mentioning it, as just keeping up with what is our other non-COVID related things. Infection prevention has a lot of mandatory reportables and things that we have to do, and that a lot of our reimbursement is tied to. So just really making sure that we have good processes in place that ensure ongoing compliance in areas that are outside of COVID. I think there's been such a hyper focus on COVID that other areas could have suffered if we hadn't had good practices hardwired. So I think that kind of just reiterated that all of those care bundles and audits and things that we had in place before that might have seemed just like a task to check off really do mean something, and it helps show that we are not straggling or not losing steam in all of our regular tasks.
Yeah, I would. Go ahead, Damien.
Oh, go ahead. No, please go ahead.
I would echo, obviously, what Bethany says. I think the other thing that was very important from a lesson perspective is, we as healthcare workers, we're in this together. And I think relying on your community and relying on, each one of our organizations, our professional organizations to help us out was very important during this. I tell my staff often that, we in support services, whether it be sterile processing, infection prevention, or HTM, right? We don't necessarily compete, right? From a hospital perspective. Hospitals may compete with each other for patients, but we don't need to compete, right? We're all here to support our patients. And so being able to reach out to colleagues in other places and take what they did and learn from it or adapt it to meet our needs. I think that's one of the only reasons we made it through the first time is we didn't need to reinvent the wheel for absolutely everything. In places like Nebraska, who came up with, cleaning models and shared them widely, right, without any thought of keeping them proprietary, was really one of the great things that came out of COVID. And it's a really good lesson to take away. We don't need to compete on keeping our patients safe. We can work with each other and learn from each other to really move forward all of the work we're doing in a little bit of an easier way. So that would be my biggest lesson I learned.
No, that's spot on. I was going to kind of hint on that as I'll expand on it because it is so appropriate of reaching out to what I call our friends across the aisle. I've reached out to competitor hospitals for, hey, I had extra of these, but I'm low on these. What do you have? Just bartering and begging and not stealing, no, not that, but just making sure we had everything we needed, making sure they had everything they need, but going across state lines, reaching out to friends and my vendor friends. I can't tell you, our vendor community really stepped up where they couldn't come in here and necessarily support the hospital directionally. I reached out to vendors around the globe literally and saying, well, this is what we're doing. I know you're challenged as well. What can you do to help? And the outpouring of resources and research and evidence was, while we were learning this stuff was amazing. And I want to see that continue. The one good thing is I know I've got two new good friends and colleagues right here that we're going to share with, already friends on LinkedIn and all that other good stuff that we use on social media. So expanding your network and expanding your ability to reach out to other people, I think has been more so grown or more so adopted from the COVID days and current days.
I agree, because I think some of the CDC guidance, although it tried to be specific as much as it could, was a little gray. And so having other different organizations that are like yours, or maybe not even like yours, to fall back on and to ask questions. One of the ones that infection prevention kind of has struggled with is in the aerosol generating procedures. I'm sure you all hear that. That's been big for us. And if we wouldn't have had other facilities to hear and see what they're doing, I think that would have made it a lot harder to come up with our policy.
Okay, well, from a general public perspective, we've learned a lot about the roles of essential workers and how critical they are to keeping society running, and we owe a debt of gratitude to our frontline healthcare workers. So thank you to all of you. I want to shift into audience questions now. Just a moment to open this up. Okay, so we have a question from somebody who works for a medical supply equipment recovery organization that repairs and refurbishes medical equipment for use in underserved communities in third world countries. And the question is, what can they do for their partners in disadvantaged communities to help them prepare for the challenges of the pandemic?
So
I'll try to take a, oh, sorry, yeah, you can go first because I'm going to take a.
Let me take a stab at least to begin with, Bethany. I think, I would recommend reaching out to the local partners that you have, either healthcare organizations or even home health organizations or nursing homes. I know a lot of them are looking for resources, but don't necessarily know who to reach out to. And so, continuing to grow your network of people and even reaching out and saying, hey, this is what I have, how can I help you? Or is there something that you need I can connect you with? I think our vendors have been doing a good job trying to ask about what we actually need. And that's been very helpful to us because some of the time I don't even know what's out there, or I don't know about vendor partners that are right around the block for me. And so being open and available and reaching out, I realize sometimes it's difficult to get the right contact name and number, but we're sharing information very freely between organizations and between departments. And so I really just would say make yourself available as much as you can and get your name out there so that you can become a resource to those individuals.
I agree as well. I think the same. And then for infection prevention, kind of would look at doing risk assessments. I know that's kind of the boring answer, but really just doing risk assessments and looking at what guidance is available, either from the World Health Organization or from the CDC, and really evaluating what you can and can't do and adjusting resources as accordingly. If you can't provide N95s for all healthcare providers, what could you provide for them? Just kind of looking at what your options are.
I agree. I've got nothing new to add on to that one. I think everything that said is spot on.
Okay, thank you. Our next question is, what are the recommendations on infection control during servicing or repairing of equipment?
So it kind of depends on which equipment you're talking about. For the most part, we haven't really changed anything. If something could be aerosolized, that obviously would be a little bit different. But for the most part, all of our practices for cleaning have been the same. As I think Damien was mentioning earlier, COVID's not really especially hardy. It's not something that requires, it's not spores, it's not something like that where we require this extra special cleaning materials to actually clean and disinfect appropriately. So I would say there's not really anything extra that you would need to do, just overarching. But again, if there's specific equipment that may aerosolize and you know that it was used on a patient that had COVID, then you may want to reevaluate and potentially use an N95 if that's an option.
Yeah, and I agree with you on that, Bethany. I think the one thing that I always was an advocate, probably didn't push for as much before, is if a vendor's coming in and servicing any piece of equipment, and I know Sam will probably be saying yes on this one, but talk to the end users prior to starting your PMs or your work or any kind of maintenance on something. Find out a little bit more about the unit that you're in, find out a little more about where that equipment's been and what it's being used for. Because sometimes, like she said earlier, we've used equipment for other purposes that you normally wouldn't have. So I think that repair vendor or that technician should dig a little deeper and find a little more about what's going on prior to just following their standard protocol.
Thank you, David. I'm nodding my head here, and I agree.
Okay, well, thank you all. We're just at about time, so I want to thank our panelists, Sam and Bethany and Damien again, and many thanks to our audience for your attendance today. I'm going to turn it over to my colleague, Danielle McGeary, to wrap us up with some closing remarks.
Yes, thank you all again for joining today. And again, a huge thanks and a word of appreciation to all of our healthcare professionals that are selflessly working out there every day. We're so proud of you and appreciate all your work so much. And this webinar will be available on demand at AAMI has a whole COVID page just dedicated to COVID resources, and that website address is aami.org/COVID-19. So definitely check out those resources, and this webinar will be available for others to listen to if they missed it. And anyone that attended this live will receive an email from GoToWebinar about 24 hours after this event with your participation certificate for your CEUs. So thank you all again, and have a wonderful Thanksgiving.
Thank you.
Thank you.
Thank you all.
Thank you.